and we'll continue our discussion of the Achilles tendon. So we talked about Achilles tendon tears, but a major area of failure of the tendon bone function is really at the tendon insertion on the bone, and it's given kind of the name of insertional tendinopathy. And wherever you have tendon and bone come together, what you will often have are bursa, which we can see here. On the bone side, you'll have a fibrocartilage. On the tendon side, you'll have fibrocartilage. Again, tendon and bone don't like to meet each other. And then you often have macrophages here, vessels and so forth. So this is kind of, and this is the synovial membrane, which we see here with macrophages deep to it. Typically, the pathology here is you get traction injuries, and then you kind of get tear of the mechanical attachment of the tendon to the bone, and then you get reactive changes in the body trying to heal that. And then we can end up with chronic pain syndromes and insertional tendinopathy short of complete tears. So, Michael, what do you think of this case?
Okay, so we see marked thickening of the distal Achilles tendon right at its insertion of the calcaneus with increased signal. And it looks like there might be some fluid signal kind of right at that interface with the calcaneus going in posteriorly. So at least, tendinosis and partial thickness tear at the insertion. But it looks like there's still some intact kind of anterior fibers, a lot of edema within the calcaneus itself. I don't think there's an avulsion. It's hard to, yeah.
This is a partial tear, insertional tear with some traction injuries to the bone, and we can see a lot of.
It looks like partial tear, isn't it, Sean?
Yep, a partial tear, exactly. Ashley, what do you think of this one?
So here we can see that there's focal edema at the distal Achilles insertion at the calcaneus. Looks like a focal insertional tear on September 1st, 2006. And looking, it looks like it's partially healed here. You can see that there's been a significant decrease in the amount of edema and also decrease in thickening of the distal Achilles tendon.
So if given rest and appropriate treatment, these partial tears can actually heal given time, which we see here. The problem is a lot of these are in athletes. They want to continue to work out and do their athletic activities, and they don't really allow enough time for these to heal. And the problem here is the one of what both the patient and the doctor think are appropriate time for healing. If you have well vascularized tissue, then often the healing can occur in the matter of weeks. You can have a bone fracture in 6 weeks, it can be mostly healed. The problem with the distal Achilles tendon is that it's not very vascular. So healing in this area takes much longer than we would expect in other areas. Another area where healing takes a long time is in the plantar fascia down here, because it's also another area that's not well vascularized. So typically plantar fascial tears, depending on severity and so forth, take 9 to 12 months to really heal. Distal Achilles tendon can take a long time to heal as well, and a lot of people get impatient and don't allow healing to occur before they go and re-injure it again. And here we can see in this case, there's substantial healing between these two studies.
In my opinion, the longer the better. I would probably get an MRI before I would allow activity.
Good.
So here we have two sagittal images of the ankle, and we can see that it looks like a complete tear of the distal Achilles with fluid in the retrocalcaneal bursa, maybe high grade.
If it was a complete tear, it would retract.
Yes.
I think so. I don't think it's a complete tear. This one is probably easier to treat than a higher tear where it's separated. All all you need to do is put the foot in the plantar position with an extra heel on the shoe or cowboy boots or whatever. Those are good. Anything to take the pressure off the tendon insertion, you'll do well. But I don't think this is a complete tear. Do you?
No, I think this is a partial tear, but it's probably a high-grade partial tear. We could also see a lot of bone edema here, and
That I agree with.
yep. And we'll see in a minute what happens when these are chronic and you get bone edema here. Remember, bone likes to make bone, bone likes to grow, bone likes to heal, and we'll see that. So, Michael, what do you think of this case?
Okay, so there's quite a bit of edema in that superficial calcaneus, which looks, fairly prominent. I don't know if it's just kind of the cut, but it looks kind of like a weird angulation of that calcaneus in general. But I think this might just be kind of like a Haglund deformity. Yeah. So is this just like a Haglund deformity? Not quite yet.
Precursor to it. Some people will call this insertional osteitis. Again, these are probably traction injuries where you're actually fracturing subcortical trabecular bone, and then you're getting a lot of granulation tissue to try to heal that in this particular location. And if as it tries to heal itself, it can start kind of overhealing, and then you get something like this. What do you think of this issue?
Here you can see a significant amount of fluid within the retrocalcaneal bursa. You can see almost a deformity of the superior superior calcaneus, almost like a Haglund deformity there. And you actually.
Why do you say almost?
Yes, a Haglund deformity.
That's a start of one.
That's pretty.
It's just not too big yet.
Yeah. And these I think tend to occur because of chronic bone reactive changes, and you get hypertrophic bone formation. It kind of due to the traction injury and the healing response. And this is the same mechanism that produces marginal osteophytes in joints, where you get injury to the bone at the capsular insertions. And in this location, it's just called a Haglund deformity. These tend to be painful. Not so much that the Haglund deformity may be painful, though they can be, but the cause of this is the surrounding inflammatory disease involving the insertion of the Achilles tendon, and this is very tender and painful. Okay.
Okay, we have a 41-year-old female with right heel pain and swelling for 18 months. Right
is on your right, left is on your left.
Right is on my right? Okay. I don't see a clear Haglund deformity.
What's the difference in contour between the asymptomatic side and the symptomatic side?
Okay. So there is slight protuberance of that posterior superior aspect of the calcaneus. Oh, I see. It could be an early enthesophyte, or here we go. Okay, so I would call this a small Haglund deformity.
I agree with you.
So this is a Haglund deformity here. We can see some fluid in the bursa here, and there's actually going to be thickening here of the Achilles insertion. If we had an MR scan, we'd see a lot of abnormal signal intensity in here. Again, insertional tendinopathy. And here we can see even some erosive changes you can get in these on the CT scan. Oh, I guess we do have an MR scan. See, I was lying to you. We don't see the tendinopathy after all. I thought we would. But here we can see the little erosive changes here, and this is a Haglund deformity. In this case, there's not a lot of edema within it. Often, when it's hot, you can see a lot of edema within the Haglund deformity. So if you If you're in the area of a bursa or a tendon sheath and you have mass with low signal intensity on T2 weighted images, the differential really is pigmented villonodular synovitis, chronic hemarthrosis with hemosiderin deposition into the synovium, chronic RA, which actually a lot of the acute changes turn into fibrotic changes, chronic infectious disease such as TB, amyloid, and gout can all present with low signal intensity masses there. Okay, so here's a case from Korea.
Just for me, or?
So the left foot looks like there's more kind of internal angulation of the calcaneus, kind of like a hindfoot varus.
That's his position.
Is that just positional? Then I see if you look on the right versus the left, I'd say I don't know if that's positional as well, but the left in the region of the Achilles insertion looks swollen. Like it looks like the soft tissues are swollen.
Well, the major thing here is you see all this erythema on the right side, which is the symptomatic side.
Okay.
It's callousing.
And when they went in and looked at it, they went in arthroscopic. It was a little arthroscopically, and then it was a little open procedure, and removed some masses there that they could palpate in the bursa, and it was basically chondroid type tissue in that area. So this is basically chronic insertional enthesopathy here at the Achilles insertion here, with a lot of inflammatory changes around here, and this patient had a little Haglund deformity and had a lot of bursitis in the bursa around here. And in this case, they had these cartilaginous little bodies inside the bursa due to the chronic inflammatory changes. Okay, Ashley, what do you think of this case?
So looking at the distal Achilles tendon, it looks like it's ruptured and retracted. Looks like a complete tear there. And looks like, yeah, definitely a gap. Looks like a grade 4 tear.
Yep, so this was a big ruptured tear. Good.
All right, so we have two sagittal images of the distal Achilles, and we can see some edematous posterior calcaneal enthesophytes. I don't see a tear in the Achilles, but this could indicate some chronic osseous inflammation and tendinosis.
So this patient was...
I think you have a little partial tear there.
Right in here, a little avulsion injury to the bone.
Yeah.
So John, what would you do for this?
I would give him an extra heel to walk on, and no sports.
Okay, one of your colleagues operated, and this is what the postoperative films looks like.
I'm sorry to hear that.
All right, so we can see some fixation hardware in the posterior aspect of the calcaneus, and I do not see the distal insertion. It looks like there may be a full thickness tear with retraction and fluid.
I don't like those devices either.
Yeah.
And you can see the result. It's not a good one because it's already torn and separated.
Yeah. Okay. Ashley, what do you think of this case?
So looking at this sagittal, is this a stir image? You see basically looks like the mid substance of the Achilles tendon. I can't really well visualize it. seems to be a lot of edema in that region. There's a lot of muscular edema posteriorly, and the Achilles tendon is following it down and following it down. As that's the last image. If it doesn't continue distally, I think there's probably a pretty bad diffuse Achilles tendon injury and possible rupture of the mid-substance later or distally.
It was retracted back, and it always looked like there were a few little fibers going along here, but there were kind of tearing of the fibers and stretching of the tendon, and then you could see all the edema within the muscle. So it was a pretty extensive acute injury.
The tears are in various parts of the tendon, not in just one location. So it's like spaghetti. If you pull it apart, you pull different parts of it, and some are longer, some are shorter in terms of longevity.
Okay.
Okay. So I see it looks like full thickness tearing of the distal Achilles with fat signal intensity. It looks like a chronic tear, and it's fluid. Okay, fluid and chronic tear, and it looks like there's fatty atrophy of the gastrocnemius muscles.
So this is a little bit more. In this case, the signal changes within the muscle are actually chronic changes of disuse.
A lot of these have chronicity to them to begin with, degenerative disease, and then on top of that they get a tear, so they already is swelling before the actual tear occurs. And people will complain of pain and swelling in the area, and before the days of MRI, we used to plantar flex the foot, raise the heel, and prevent further damage by preventing sports activities. And most people will follow the instructions if you really tell them what can happen.
Okay, so it looks like we have a mid-substance tear, the Achilles tendon probably a few centimeters above the insertion, with significant amount of surrounding edema and swelling. I wonder if there's like a single intact fiber, but I just call it complete tear.
So is this acute or chronic?
Well, actually, on the STIR image, there's not. So that actually looks like that. There's actually a lot of edema, so it probably looks actually somewhat chronic.
This is chronic, I think.
Yeah, with that in it really indicates it's chronic.
And it's not complete. It's got a ways to go yet.
Ashley,
There's some fibers intact, otherwise they'll be flying up.
Ashley, what do you think of this one?
Well, I noted there's a lot of edema within Kager's fat pad. There's also thickening of the distal Achilles tendon, and it looks pretty amorphous. I don't see normal low T2 signal. There is also remodeling of the posterior calcaneus there superiorly. There's some traction changes there, and there might be some partial tearing even distally of the Achilles tendon, but it looks pretty severe.
So this is another chronic insertional tear with a lot of the peritoneum, what's called peritonitis or tendinopathy associated with it.
That is an osteophyte there, isn't there, John?
Yeah, I think this is kind of a oddly positioned Haglund deformity. This is probably due to the chronic traction injury.
Yeah, I would think so. I wonder what the other foot looks like. The last Haglund deformity I saw in my practice was an ice skater that was heading for the Olympics, and that prevented it.
Well,
Ice skater.
Yep.
Here
Here we have a 45-year-old male with bilateral Achilles pain. I would want to know how long he's been having this pain. This kind of looks like chronic tears of the bilateral Achilles tendons with retraction. Certain sports, I think, can create pressure in the Achilles, or equipment, certain sports equipment.
I'm not sure about that. You know, there are some genetic diseases.
this doesn't look like the usual kind of a tear. This, like you said, John, I think there's some kind of genetic pathology here.
Trying to find my block.
Would you be in for quinolones?
Yeah, yeah, morphins may be one. Why am I blocking? There's a relative who has it. No, it's. I'll think of the name in a minute. The name, Mongoloid is a name that's a bad name for it.
Was that medication that's taken?
So,
There you go.
Yeah, ciprofloxacin is known for it, right?
yeah,
Yeah,
Levaquin. And then what antibiotics, other antibiotics?
Ciprofloxacin will do it.
Cipro is probably the most common one.
That's the most common one.
Okay, so first thing I notice is pretty big retrocalcaneal bursal effusion with increased signal within the adjacent Achilles. Yeah, retrocalcaneal bursitis or pre-Achilles bursitis.
Ashley, what do you think of this one?
There is significant remodeling and traction changes at the posterior aspect of the calcaneus. It almost looks like erosion, actually. I don't know if this could be seen in different pathologies like gout.
Yeah, you certainly have to think about gout, even rheumatoid arthritis. But most of these in this location are due to chronic traction injuries, where you basically fracture some of the bone, tries to heal, and you get these erosive changes. And remember, histologically, a lot of the erosions that you get with rheumatoid arthritis, you have a similar type mechanism because they tend to occur where capsules have the highest tension where they attach to the bones. But these are insertional erosions. They could be due to inflammatory disease. You certainly have to think about that, but you don't have to have an underlying inflammatory condition to get these kind of traction erosions.
You should have some swelling if it's gout.
Yeah.
61-year-old with right heel pain for years. He does have some posterior and plantar calcaneal enthesophytes. There may be some increased signal in that central band of the plantar fascia at the calcaneal attachment, but I don't see a tear on these images. So some plantar fasciitis. May also have a small Haglund deformity. The distal Achilles isn't too bad. HLA-B27 positive. Okay, so we're thinking.
Positive for gout.
Yeah. Ankylosing spondylitis.
Spondylopathies can affect any
I'm sorry. HB27. I'm sorry. It was.
Yeah,
I made the wrong comment. Ankylosing spondylitis.
That's okay, John. This is ankylosing spondylitis, where you can get a lot of these changes. You tend to get enthesopathies throughout the body with ankylosing spondylitis and ulcerative colitis and those kinds of diseases, Crohn's disease.
Of interest, I've never seen a case in this area.
Interesting.
Only in joints, not in this. That's not a joint. So.
There's a 69-year-old female fell on her ankle, incidental calcaneal lesion not seen on x-rays but seen on bone scan. So they have increased radiotracer uptake in the bilateral posterior calcaneus, probably like at the Achilles insertion. On CT, I just see kind of some sclerosis of that region, nothing, but no like erosive change or anything, or no. Oh, okay, now here in that region of sclerosis, we see pretty increased fluid sensitive signal and kind of low signal on T2. So well demarcated. Sorry, I mean dark on T1. And
What's your best guess?
I'm not sure. Like I said, it's not erosive. It just looks like really well demarcated edema or fluid.
That sure reminds me of gout.
Yeah, like it's just some inflammatory insertional.
Yeah, this is just chronic traction injuries, insertional arthropathy,
Yeah.
and a lot of people attribute it to bad footwear. But it's probably more of an overuse rather than definitely. But you certainly can have shoes press against this, and it's very tender, and it can be very uncomfortable to patients. Okay. As you.
All right, so we have a 10-year-old male with heel pain. I think this is the beginning of apophysis. It looks pretty edematous. I think you can see this normally. You can have a pretty variable appearance of this. It can look fragmented, although it is you could have apophysitis. It is pretty bright.
I don't think this is normal. And this is called Sever's disease, which is calcaneal apophysitis, which are chronic traction injuries to the apophysis before it fuses. And in this particular area, it's called Sever's disease. John?
My granddaughter had it, so I'm familiar with it. No, I've seen a lot of cases of this. It usually occur around 8, 9, and 10. But that's for some reason they don't occur in other ages.
All right, this is an 8-year-old female with a protruding mass in the right heel and tenderness. We do see on the plain film some soft tissue calcification along the posterior superior calcaneus, and there is some cortical irregularity. So I wonder if this could be Sever's disease with some osseous fragmentation, like an advanced case. Here we can see edema, avulsion fracture.
This is probably a little bit more severe than just Sever's. This is really a avulsion fracture of the apophysis, so kind of a severe form of Sever's disease. Yeah. This is what it looked like 9 months previously. Ashley, what do you think of this case? Different age group.
So this patient has chronic heel pain, so it looks pretty normal to me. No, I'm just kidding. There's a lot of remodeling of that posterior calcaneus, and there's a lot of fragmentation there, and there's actually extensive vascular calcifications too. I don't know. This patient could have some remodeling of this bone. It looks like a avulsion fracture, straight off. Avulsion fracture probably could heal with surgery.
John?
The first thing I would think about is infection.
Yeah, that's a good thought. But I don't think this patient was infected, and I don't see a lot of fluid around it.
No, I understand, John, but that's the first thing I would think about.
at this stage, right?
on the X-ray.
Yeah, right. So this just turned out to be a chronic avulsion fracture.
That's kind of a peculiar looking avulsion fracture.
Yeah.
It's deformed.
I think we're looking at some coronal images of the lower extremities, and there's some edema and fluid along that medial head of the gastrocnemius. So I'm concerned for a distal Achilles tear, or it could also be muscle injury. Yeah, partial grade 2 injury of the muscle.
So 34-year-old male radiologist, it felt like I was shot from behind while driving for a layup. Looks like there's a lot of edema within the posterior muscle here. I think this is probably at least a grade 1 to I think grade 2 strain from the muscle here. Increased edema of the gastroc muscles. I'm not sure what they're pointing out. Oh, is that a torn tendon?
What is that? That's the plantaris tendon.
Just trying to follow it. Is it? Is that? I don't know what that is. That's not the the Achilles, is it?
That's the plantaris tendon.
Plantaris, okay.
And then we can see
That's a very common complaint with plantaris tendon. They feel like they got shot.
There's a little bit distally, but we
can almost make the diagnosis by history.
But here we can see a lot of edema in the gastrocnemius. Here's the plantaris. We're following it down through. There's the plantaris, and now we can see a lot of edema adjacent to the gastrocnemius, and that's bright on T2. And then, but we can follow the plantaris all the way down. So for a long time, we thought most of these injuries that had this story where you had fluid in the space between the soleus and the gastrocnemius were plantaris tendon ruptures. More recent studies have looked more carefully at this, and you can occasionally get plantaris tendon ruptures, but the majority of injuries that come in with this finding aren't plantaris tendon ruptures. They're actually tears of the gastrocnemius muscle and or soleus muscles, and then they have hemorrhage into the space between the two. Not they're treated the same, so it's not that big of a difference. Just be aware that typically these are muscle tears directly and not plantaris tendon ruptures.
And that's why the floor in basketball courts have gifted them so that it doesn't put so much pressure on the calf muscles. I don't know whether you know that or not, but when these guys are running down the floor, these giant guys, there's a lot of give in that floor to prevent them from getting this injury. But they still get it. But the professionals rarely ever get this problem.
Yeah.
So it's just usually the guys out in the cement trying to jump that get the problem.
I was wondering if it's also might be possible to tear the fascia or the myofascial planes surrounding the muscle when you have all that fluid there. Yeah.
Yeah.
Okay, so this is a 14-year-old male. Gosh, there's edema in is it the soleus muscle?
Well, but here's the Achilles, so this is really the pre-Achilles fat padding through here.
Okay, so this would be another, like a peritendinitis. The Achilles itself looks okay.
It's on the medial side.
Okay, medial side.
This actually, here you should see a little black structure, which is the plantaris tendon. Okay. This was actually a distal tear of the plantaris tendon with hemorrhage into the space around the plantaris tendon.
One thing to remember, I think something like 25% of patients don't have a plantaris tendon.
Yeah, it's something like that. I don't know the exact number.
I think it's 25%.
Ashu.
So this is a 44-year-old male basketball player with acute ankle pain, acute calf pain. You can see, almost see heterogeneous lobulated signal there. It's pretty intermediate, actually. I don't know if that's fluid, but it's acute. So are we looking at another plantaris tendon? You see that fluid near the medial gastrocnemius. Yeah, so plantaris tendon.
But you can see the plantaris tendon going.
Plantaris tendon is intact, actually. Yeah. So is this just a tear of the medial gastrocnemius with hemorrhage?
Yeah.
Muscle bleeds. The tendon doesn't bleed very much. It just causes edema.
Yeah, so this was not a plantaris tendon rupture. This was a gastrocnemius muscle tear. Yeah. I need to go back and change this. Good. Okay, Michael.
Yes, 52-year-old rock climber, jumped, landed, and hard push off. Now with knot on medial side of calf. So it looks like there's, we see right there, you're seeing the kind of medial gastroc head. Looks like there's some fluid distally, like within the muscle belly. And I'm wondering on that first image, it's kind of coursing in between, like the gastroc itself is a little edematous, and there's some fluid in between the gastroc and the soleus, I believe, kind of in that kind of tendinous fascial plane.
So what do you think this is?
Assume it's kind of like a distal tear of the medial gastroc.
It's kind of in the middle here.
Yeah, like where it's kind of conjoining with the.
Yeah, but why is it black?
Oh, what's the? I thought that was.
Torn and retracted.
Yeah.
What we see here is you see a fluid collection here within the gastrocnemius, and you can see all of this black structure here. So what could give a black signal like this?
Do you think we'll want like tendon or blood?
Okay, so this actually is chronic hemosiderin deposition from a chronic tear of the gastrocnemius, because this patient continues to play tennis even after they injure themselves, and this is called tennis leg, and it's relatively common. Tend to occur in middle-aged people. It was first described back in the 1800s. It's been in the past attributed to rupture of the plantaris tendon, but now most studies show that it's actually chronic tears of the gastrocnemius rather than tear of the plantaris tendon. If you tear the plantaris tendon, you get a pop and you get a little bit of hemorrhage, and then it goes away, and it doesn't create these chronic kind of lesions like this. And typically it involves the medial head of the gastrocnemius. Can also involve the soleus. Okay. What do you think?
37-year-old with mental retardation, cataracts, and masses for 5 years. I think this is probably some type of collagen disorder. Wow. So just diffuse thickening of the Achilles tendons. So some type of collagen deposition disease. Or cholesterol.
It's actually Cerebrotendinous Xanthomatosis. So you can, but it just kind of puts in the category of xanthoma within tendons, because you will see xanthomas in practice. Ashu, what do you think of this case?
Seems like there's significant thickening of the distal Achilles tendon, or actually, the Achilles tendon might be posteriorly displaced.
This is.
Sorry, yeah, it almost feels like there's something in the Achilles tendon. Maybe this is another xanthoma.
Okay, so it could be kind of a chronic injury where you get rounded and big like this. But when they're really huge like this, especially when they're like lumpy like we saw back here, see how kind of lumpy bumpy it is, that's typically xanthoma. And this is another xanthoma within the Achilles tendon. Okay.
So a 50-year-old female. So we can see the just marked thickening left greater than right of the Achilles tendons. I think they're giant. And now we can see there's kind of diffuse low signal infiltration on fat saturated sequences throughout, on both fat and unsaturated sequences throughout the Achilles tendon. The other tendons I don't think are involved. So again, I was wondering if this is just like a xanthoma. And the case I have seen in this, it did affect like the
So here we can see prominent soft tissue in the region of the bilateral Achilles tendons, greater on the left than the right. And here again, we can see diffuse thickening and infiltration of the bilateral distal Achilles tendons, probably again are compatible with xanthomas or cholesterol.
Upper cholesterol. Ashu?
Sorry, did you say my name?
I did.
Okay. Looking at the distal Achilles tendon, looks like there's, first I noticed some marrow edema of the calcaneus, and maybe some insertional stress injury. And then there seems to be either a partial tear of the distal Achilles tendon, or it could just be another xanthoma, I guess. It looks like there's actually some intermediate signal. Doesn't look like fluid. I think this is most likely going to be in. Sorry?
What do you got a lot of bone disease, as you were saying. So what might this be?
Well, I guess you could consider like a gout. Okay.
Yep, gout. Good. And you could also consider xanthoma and so forth, but this is a kind of a characteristic appearance of gout. Okay, Michael.
Okay, so 29-year-old male with Achilles surgery 5 years ago for tear. Now it's pain and swelling, rule out abscess, or 5 years ago. So the mid-distal Achilles tendon looks markedly irregular with this kind of circumscribed collection. It's bright, but it's not, I don't think it's entirely cystic. Yeah. And so there's some, on the right image, there's low signal intensity within the collection, which is kind of partially enveloping and infiltrating within the markedly thickened and abnormal Achilles tendon. And as I assume that's a T1 on the left. That's kind of a low signal. I guess this could, if they're actin infected, this could be like kind of a phlegmonous type collection, if that's what they're worried about, but it's going to be something inflammatory.
Whatever you think gout, you think infection, but just all the margins look so sharp here that this is more characteristic of gout. Okay, guys. So I think we'll end here on talking about tendons of the foot.